Hello and welcome to episode 5 of OrthTeam Unplugged. Today we are talking about where sports cardiology meets SEM. I'm delighted to be joined by Professor Aneil Malhotra, sports cardiologist, and Ron Bhattacharya, consultant SEM. Welcome, guys.
Thanks for having us.
So that is the title. So I'm going to come to you, Aneil. You're really prominent, see you on TV a lot talking around. You're very involved in this area. So where does sports cardiology meet SEM?
Well, I think it's important to acknowledge that what we see in the media is usually based on someone having a cardiac arrest on the pitch. You know, the high profile events that we see even most recently with, the footballer that's had a cardiac arrest on the pitch with an ICD. And that's one of the facets of sports cardiology, trying to identify at-risk individuals and trying to mitigate that final cardiac arrest happening on the pitch. And the various steps need to be taken before that, including screening, so trying to identify at-risk individuals. And that works in tandem with secondary prevention and the importance of recognizing collapse and sudden cardiac arrest and trying to initiate that chain of survival with cardiopulmonary resuscitation, CPR, and getting a defib on. And obviously we're relying on the sports and exercise physicians and the pitch side physios and doctors to help facilitate and instigate that process in order to get a successful outcome. So I think that's where the interface is, Andy.
From your side?
Yeah, kind of reflecting similarly on that. Three main facets where Neil and I have worked together over probably about 5 or 6 years now. One is in screening, trying to pick up early warning signs in asymptomatic individuals, in exercisers and athletes. And then the next steps, if we do pick anything up or if anyone has any symptoms, the processes on investigating this further, making decisions around safe return to sport and what level and how we do that, and any subsequent monitoring that is needed. And then the other big part, which is often forgotten a little bit in sport, is that kind of EAP, the emergency action planning at your venues, at your sites. Having a robust plan in place in terms of equipment, staffing, resources, finding your weak spots, and then also stress testing all that and running scenarios at your clubs or facilities and really seeing where any weaknesses lie and filling those gaps.
Some of the most shocking images that I can remember for me when I've watched particularly football and these incidents happen, have there been an increase in those, or is it just that they're more prominent now because there's so much emphasis on TV? Like, have things changed physiologically from athletes?
Well, I think there are 2 points to mention on that. The first is that historically there have been underestimates of the incidence of sudden cardiac death. Work that we have done, even as part of my own PhD research, showed that those estimates were 7 times higher if we look at trying to really identify a well-defined denominator. It's very difficult to estimate sudden cardiac death rates on a population level if we've not got a well-defined population. And the FA's cardiac screening program, which is the longest standing of its type over 3 decades now, has that. We've got a well-defined group of scholars, which stands at over 20,000 now, that we've been able to follow up over a number of years and identify at-risk individuals. And have a more accurate estimate of sudden cardiac death. So I think the ways to detect and report sudden cardiac death have improved. I also think the visibility of these events has certainly increased exponentially. We know if someone's had a sudden cardiac arrest on the other side of the world within elite sport in today's era of digital media, social media, and therefore the visibility of these events is much greater than ever before.
Like, for you particularly then, so how has your role changed then since you started in this area?
So I started when I was a research fellow at Cardiac Risk in the Young, CRI. They funded my PhD at St George's University of London with Professor Sanjay Sharma as my supervisor. And I joined there in 2013, having moved from Oxford, where I was undertaking my cardiology training. So took a period of time out to do a PhD, funded by CRI. And then I really was interested in the conditions that affect younger people, conventional coronary artery disease is what our exposure was as trainees. But what fascinated me was, why do young people suddenly drop dead, or why do young people get affected by cardiac conditions? Seemingly healthy individuals, 80% of cardiac arrests in young people between the ages of 14 and 35 have no symptoms, and so they suddenly collapse and have a cardiac arrest as they're presenting symptoms. So that area particularly fascinated me, and that's why I sought out research opportunities through CRI. And with Professor Sanjay Sharma's team, we ended up screening academy level teams in football, in basketball, in rugby, and then the more senior teams as well, all through to elite level. So between 2013 and 2019, I gained great exposure into this area, and I really enjoyed it. And the knowledge base has increased, the demand for the expertise has also increased, and the North is a huge hub for sports. I was originally from Manchester, from Bury, born and brought up there. And then, so it kind of was going full circle, having trained down south in Cambridge, Oxford, London, and then moving back home, as it were, to Manchester to work with Ron and his colleagues to help impart some of that expertise to the huge number of athletes in the North.
So I know that OrthTeam are putting a big emphasis on this. So can you talk to me more about what that's going to entail?
Yeah, so I've started OrthTeam recently as a consultant in sport and exercise medicine, and Aneil will be joining us as well. We've got some exciting developments in terms of an expansion, a second floor, which has more clinical space, more radiology space, but also a cardiorespiratory suite where we're going to be able to start doing these exercise testing, this cardiac screening, and have that as a northern hub really for cardiorespiratory investigation in athletes, but also in exercising individuals. Obviously, we were talking about the increase in cardiac events, and probably I'll just add to that, we're seeing an increase in people exercising to a higher level in a lot of different sports nowadays. We talked earlier about high rocks and paddle, and I've got to get in here that I do Brazilian Jiu-Jitsu, and there's lots of people doing that to pretty intense levels in terms of their training volume. So we're seeing more hobbies kind of get professionalized in a way. So more opportunities to support people with their cardiac health.
And I think that people really are investing in their health, which is great, really, really important to do so. So, and we always talk about and see the high profile athletes. However, there's, that's an absolutely tiny fraction of it, even within professional sports. So what is your advice to teams, or to then even going down to people that are just amateur athletes, but take it really seriously?
I think probably the biggest change recently at club level, talking about kind of club sport, has been the 2025 FIFA guidance on cardiac screening. And what we are now doing is screening players from the under 13s and upwards. So 12-year-old athletes, under 13s, under 15s have ECG screening. And then from under 17s onwards, we implemented annual ECG and echo screening, and then any further investigations were discussed and led through with Aneil.
The OrthTeam, coming back to Ron's point, is investing substantially in a state-of-the-art cardiorespiratory lab, whereby we'd be able to undertake athlete assessments, not just screening, but echocardiograms, stress echoes, exercise treadmill testing, further investigations, ambulatory leadless monitoring. And that'll be working with Ron and his colleagues, leading colleagues in the field, John Rogers, Jim Cares, David White, and Rebecca Robinson, for instance, amongst others. And therefore, there's going to be a great expansion in the sports cardiology services there. And the OrthTeam have also teamed up with Cardiac Risk and the Young, and are the only main centre outside London that has dedicated screens as a national northern centre to undertake community screens. And that involves about 100 people a day between 14 and 35 attending the OrthTeam Centre for free, because the funds have already been raised by a family that have unfortunately been affected by sudden cardiac death. And we look for conditions through a simple health questionnaire and an ECG, and they get to see a CRI fellow on the day. If they need further investigations, then that gets instigated there and then as well. So there's some exciting ventures that are coming out of the OrthTeam.
Before I come to you there, Ron, like practically, how do they engage with you on this? How long does a full screening take? Do they come and do it on site? Like how is it done from a team's perspective?
I think starting from my role as a team physician, and there's plenty of other medics working at kind of amateur club level, and then into elite sport. It's flagging if there are any issues, any symptoms in people, reaching out to Aneil and arranging the next steps in terms of investigation. So the benefit of working with people like Aneil and the rest of his team is we can get all this done very quickly. Normally we get the next steps of investigation done within 24 hours to 48 hours of flagging a symptom in an exercising individual. The athlete will come, they will have their ECG at rest, they will have their echo, and then based on that, they will often have, like Aneil alluded to, exercise testing, stress testing, see how their heart function changes as they exercise. And that's really key in athletes. It's not just the tests at rest, it's the tests at stress. And yeah, we work up through a kind of step-by-step approach with them. In terms of the screening time frame for an individual athlete, about kind of 15, 20 minutes. And in terms of ECG and echo, and then if they need stress testing, you're looking at an hour, and the whole thing is packaged off. And the great thing with these tests are you get the feedback live. We're often I'm there in the room, or a medic is there in the room with us, and we're getting the feedback from Aneil as his team and his team as we go through the ECG report. The echo is on screen. You can tell the athlete what you're looking at, and they like to have that visual feedback as well. And then we look at the stress testing as well. And Aneil's very good at teaching as he goes. So it's always a learning experience for us when we take players to see him.
I can imagine if you've had someone that's maybe had an instance where you're thinking actually there may be an issue, it's a stressful experience for them. So what might you communicate to them if you're seeing something that is potentially an issue? Like what would that mean, and what would that demonstrate?
I think, Andy, you highlight a really important point here, because interpreting the test is one thing, but interpreting the test in the context of the athlete is very different. There's been a paradigm shift in our understanding of the tests over the last few decades, whereby, for example, in Italy, there's a very low threshold to pull the carpet from under that athlete's feet and say, you can't train and play. Data have now emerged to say, well, with certain cases, hypertrophic cardiomyopathy, abnormal thickening of the heart, which is the most common cause of heart muscle disorders leading to sudden cardiac arrest, there's been a change in our understanding. If someone's got low risk hypertrophic cardiomyopathy, we can call it HCM, then actually the European Society of Cardiology and now the American Heart Association guidelines actually help facilitate or help support a shared decision-making process whereby we sit down with the athlete, with Ron, for instance, and with the athlete's representatives, be it family or another independent club representative as well, to say, look, these are the results. This is what we think may be the problem. And then at the end of the day, it's up to me to relay that information back to Ron about risks. Now, risk mitigation can be quite difficult because the data sets then become slightly more limited with regards to longitudinal outcome data. But what we do know is that certain lower risk cases, for example, mild thickening with no scar on the MRI and no life-threatening rhythm disturbances on exercise testing or monitoring, actually, we can navigate our way to facilitate that athlete to return to play. From their perspective, that can have a huge psychological impact, be it negative thinking, how hard can I actually put my foot on the accelerator? Is something going to happen with a time bomb going off? Or saying, actually, you've put my mind at ease. I can forget about this and, hand over the responsibility to the physios and the medics pitch side to make sure that everything is in hand. Often athletes are asymptomatic and they've had a silent condition detected. And this is all they've ever done from a very, very young age. So this is their life. So I think these sorts of issues definitely have to be handled sensitively. The psychological impact can't be underestimated. The anxiety, not just for that individual, but on the family members, particularly when you get young athletes and the parents that have driven them here, there, and everywhere across the country for hours on end, are now being told all of a sudden that there's something wrong. I think that's where expediting the tests definitely comes into play, because we can give them answers there and then we can perhaps put their mind at ease. But there are a handful of cases whereby it may be too risky for that individual to continue playing. And in that case, we do need to come to a sensible decision, because at the end of the day, even the parents will prioritize that young person's life over anything else. Thankfully, those conversations are few and far between, because we can navigate our way around a shared decision-making process.
Yeah. How about it from your perspective in the club?
Yeah, I think the key is having that information early. So when you're working with athletes in an elite sport, you're working to very strict time schedules, and having all the information you can, working with top professionals in the area and sitting down with them, sitting down with players, parents, other stakeholders, and getting that information quickly is key. So having centres, hubs around the region where we can get these tests done very quickly, we can get everything packaged into one and get all that information has been game changing as such. And then the next steps it's very rare, I'd say, from my side, that we end up having those very difficult conversations where we are talking about cessation of sport. We tend to more have conversations around normal variants for different athletes, or early changes that need monitoring, and then we speak with parents. I work. The majority of my work has been in paediatric adolescents at academy level, so we involve the parents a lot, obviously. Sometimes agents, sometimes other people, sometimes coaches, and other members from the club. We talk about risk, we talk about current risk and what is predictable, and how this needs to be monitored. Normally annual checkups. We alluded to a little bit earlier about the difficulty in sport with moving parts. So a challenge that we've had a lot is with players coming in and then exiting out on loans, transfers. You get hold of a player, you do a lot of investigations, you have a plan in place, and then all of a sudden, very quickly, a decision is made that sometimes us as medics don't always know the next steps of, and the athlete may then transfer on. So having a robust way of monitoring your athletes, knowing who needs checks when, and then also handing that information over to key stakeholders at other clubs, to the athlete themselves as well. Sometimes it's difficult to get the importance of this across to athletes because they may be asymptomatic. We talked about how that culture varies. We'll have international athletes. A lot of the kind of European athletes will know of these big cases a lot, but some of the players from other parts of the world may not know our higher profile cardiac cases. And so it's a little bit more, they're a little bit more removed from that. So if you're asymptomatic and you're telling someone you need a test, they're thinking, do I really? What for? I feel fine, I'm exercising. I've had those conversations with players where they say, why do I need all this? You know, why did I need a cardiac MRI scan, which is a long, quite an arduous investigation, when I feel fine? I feel fine, doc. So it's just trying to get that information across to people, which involves more than one conversation, involves more than one person.
Mm. And like, what about the other way? Did you get people that have seen these instances and they're anxious about it without, you can sort of suddenly start, say you're feeling a little bit off or whatever. Do you get other people that are concerned about not being screened or not being tested or looking at those things?
in the larger club environments where you have the benefit of screening people annually in that kind of pro phase, or at least every 2 years from the age of 12, 13 upwards, there's a safety net in there. We definitely have had, we have some anxious players out there, anxious individuals, and they may feel normal symptoms and worry from a cardiac perspective. And often it's not always the external cases that they're concerned about. They might have a family history of something that they're concerned about. It may be angina, it may be ischemic heart disease, even just hypertension in the family that they're not sure their risk. And so we've had players who have had palpitations, for example. We have a very low threshold. Any player who has these higher risk features, palpitations, pre-syncope, it's rare that we have a player who has out and out chest pain or a syncopal episode. It's normally the softer, earlier signs that they are training and they start to feel a flutter in their chest or start to feel a bit dizzy. And as a clinician, you're thinking it's probably not something cardiac here, but we've got to follow this pathway. And so I'll get on the phone to Aneil, and he'll be available within the day, and we'll go through the motions of the investigations. But I kind of, in short, yes, we do get some players concerned about that, and some family members as well.
Yeah, and I think also we're a very high profile club, well funded club, but then where do you start with this? There's amateur athletes. Football's always the one you talk about, but that's pretty well funded. Even if you drop down the leagues, it's still quite well funded. But other things, when you got rugby, athletics, tennis, like where should screening take place?
Again, it's a very good point that you raise, and we are talking about elite sport whereby those athletes are fortunate enough to have access to all sorts of facilities. But as you go down the pyramid, if we consider an athletic individual is someone who exercises 4 to 6 hours a week, and that arguably encompasses school children as well. Running around on the school fields and PE and this, that, and the other. So I think when it comes to debating who should be screened, any young exercising individual or active person should be screened. For the sake of a quick ECG, and that's reflected in the general population as well. For example, cardiac risk in the young figures state that there's a waiting list, or there's a demand of 140,000 people wanting to be screened. So when their screenings go live on their website to say, we've got these days coming up at the OrthTeam Centre, for instance, the website crashes within about 5 minutes, less than that. And then I get calls saying, what can we do? How can we get our kids screened, or how can we get screened ourselves? So I think the demand is there, and it shouldn't just be restricted to playing for a certain elite football club, for instance. And that's why community events like CRY are so important. There are other ways of getting screened, at grassroots level. That's now filtering through. There are various organizations that are going around, screening through all sorts of newer technologies, leadless sorts of 12-lead ECG acquisition. So you're not dependent on a whole team mobilizing. But of course, then you run into other logistical issues. For example, governance, data protection, who's interpreting those screens. And there have historically been concerns about false positive rates, which have now come down significantly with a new generation of sports cardiologists nationally. And then, as Ron has mentioned already, getting into a system where you can get those tests done and expedited in a timely manner, rather than having to wait sometimes months in order to hear back from an appointment. So there are various challenges, and the infrastructure needs to be in place before saying, yes, we should and can screen everyone. But that would be the goal, and that's the aim to work towards, I think. So general population people also get screened. And I'll tell you why, Andy, because the prevalence of serious conditions is about 1 in 300. Serious conditions that can lead to sudden cardiac arrest. Minor conditions is about 1 in 60. So we talk about minor valve disorders or small holes in the heart. That's what our data have shown. In fact, amongst football academy players, it was as many as 1 in 250 have a serious life-threatening condition, and CRI's data have shown that that's about 1 in 300. And there are 12 deaths a week in the UK in people under the age of 35. And so, that's significant if you consider the number of life years lost as well, what that individual would have contributed to society and the impact that has on a community, on a school, on the family, regionally and nationally as well. So they're very, there are strong arguments to be made to actively identify at-risk individuals, the majority of whom, as I mentioned before, would be asymptomatic.
And what could be done for those 250 or 300 people to alleviate or help with that?
Well, we know from our own, if you look amongst sport, for instance, because they've got well-structured screening programs, that amongst the individuals identified from football, 75% of them returned to play. So the vast majority returned to play. If you look at CRI's data of over 100,000 young people screened over the last 2 decades, 41% of those identified, that smaller group identified, had life-changing, life-saving interventions, be it through an ICD, which is an implantable defibrillator, be it through an ablation, for instance, burning an extra electrical pathway within the heart. So interventions can be done, and the vast majority of those identified with a condition do go on to be treated appropriately through medications or interventions and end up being facilitated to play with a view to them carrying on their normal life, not necessarily even at elite sport, but doing what they enjoy doing and getting them back to the quality of life that they are used to and that keeps them healthy in a safe and responsible way.
Yeah, no, it's really important to hear what can be done for it as well. And AI has always been a big topic within the conversations we've had on this podcast. What is happening from your perspective with AI in this area?
The ECG has historically been interpreted by whichever program that device has been fitted with, and young people invariably are having an acute MI. As soon as that ECG comes through, an acute myocardial infarction, of course they're sat there happy as Larry. But it just goes on to show historically how the athlete's ECG is different from a standard person's ECG. There are lots of different electrical changes that reflect athletic adaptation rather than pathological conditions. But the interpretation of that has obviously improved and enhanced our understanding. The idea of AI is to detect pathology that may not be visible to the human eye. I think it has been validated in large cohorts for general cardiology, but within sports cardiology at the moment, there aren't any large validated cohort studies. Yeah, I mean, it's certainly an area that will develop and will have some answers, I'm sure, within a few years' time. But the variation within these cohorts also needs to be accounted for. For example, sex needs to be accounted for. Ethnicity, we know that the black athlete's ECG behaves differently from other ethnic groups. And what does black mean in itself? You've got various regions of Africa, you've got the Caribbean, you've got mixed race, we have emerging Asian populations now as well. So all these different demographics need to be accounted for when interpreting that. From an imaging perspective, there are fantastic AI data sets that can perform the measurements and significantly reduce the time it takes to undertake and interpret an echocardiogram and a cardiac MRI, for instance, as well. But for now, I think that human element is still very much there. And as I mentioned before, it's about interpreting the tests in the context of the athlete. So with it being, AI may say one thing, but actually that needs to be then relayed, conveyed, and we come back to all the kind of processes that we spoke about earlier about shared decision making and what this test may actually mean. So I think we certainly need that human element for now.
Yeah, no, good point on that. And then we've spoken a lot about elite sports, but in terms of the people that refer into OrthTeam, so we've got the independent sector, what are the things that you think should be aware of as takeaways from this conversation that they should be looking out for?
Well, I think as Ron has also mentioned, being aware of symptoms is really important, particularly in the older age group. Screening in younger people, look for electrical conditions and heart muscle disorders, which may be silent. Resting ECG may not detect silent coronary disease, which affects those over the age of 35. So furring of the coronary arteries, a resting ECG is not a very good test to detect that. So then we have a multifaceted approach, taking symptoms into account. Red flag symptoms, of course, include chest pain, particularly with exertion. Athletic people perhaps behave a bit differently from the general population in terms of their presenting complaint may be increased shortness of breath or not hitting their targets, a reduction in performance levels. That may be the presenting symptom, particularly in older individuals. And then other risk factors, including high blood pressure, including high cholesterol, diabetes, or all these other risk factors that would contribute to the more common conditions affecting older people, i.e. Cardiovascular disease, ischemic heart disease, and cerebrovascular disease, strokes. So that's what we say. Don't ignore symptoms. Get your risk factors checked because they're easily modifiable. For example, hypertension, which affects a third of the general population and is a silent killer in itself, contributing to accelerated furring of the arteries. If anyone is concerned or about any of these symptoms or reduction in performance, then they should come for an assessment.
Anything to add from your side?
Yeah, I think, as you mentioned, elite sport has a good medical and performance setup. So we may be able to support them in second opinions. Aneil will probably link in more with the club doctors and physios of the region. And hopefully where people like myself and John and Jim and the rest of our sports medicine team, now I've stepped out of full-time sport, we'll be able to do is support the smaller clubs, really. And I think that's going to be our interest is a lot of the smaller clubs in the region, whether that is even amateur, semi-professional, and leading into that kind of lower part of the pyramid in professional sport, may not have the same sort of robust medical cover from a doctor perspective through the week, and they need more support in terms of bouncing ideas off, being a sounding board for questions, queries related to cardiac symptoms and obviously beyond. So hopefully what we'll be able to do is link in with these individuals at the clubs, give them second opinions, do risk assessments on players and individuals, and then lead them into the kind of cardiac assessment service and support with screening if that's the way we go with this. And then the other thing you mentioned was the independent sector. So that's going to be an evolving piece, I think, in terms of people wanting to have their own screening done, which is happening in some places now and is a possibility for the future. So supporting individuals who are sometimes training, like we said, more than elite athletes. I've got people who train multiple times a day through 6+ days a week who kind of don't necessarily get the recovery rest days that you would if you were in an elite periodized setup. So we'll be able to support them with their individual needs or queries. So some different avenues, I think, going forwards.
So have you had any interesting cases that you can talk to us about? Yeah,
so one that always springs to mind when I think of Aneil was maybe one of our first contacts together when he was working up in the Northwest, which has been a massive benefit to us. I was screening some of our academy rugby players post-COVID. So again, after the return to sport following COVID, we had some decisions to be made on how to assess athletes who had been ill from COVID and what cardiac risk that posed to them. So one of the athletes had quite a significant COVID-related illness and had some cardiac symptoms related to that. So we had to make a decision to advise him to stop exercising at the time until he had further investigation. The difficulty being at the time, the club setup wasn't like a funded athlete on an insurance program. So this would have been self-pay and back into the NHS, which at the time we were looking at a 9+ month wait, a very important period of this player's career. He's trying to break into the development phases, into the kind of first team environment. So to remove him from sport for something, again, he had no symptoms for, on an illness he'd had weeks ago, is quite a difficult thing to broach to a teenager and his family. Aneil and I worked with him, and he supported us a lot at the time, and we brought him into the private sector to go through the next steps. But it just made that decision making a lot smoother and a lot faster. So we were able to make a decision on that athlete's return to sport within, I think it was a week in the end. And the athlete returned to sport, was able to go on to their next steps in their career.
And how do those conversations go then with them? Like when you're chatting to the athlete and the surrounding family and so on. So how do they tend to respond if it is something that they're not particularly, they're not expecting, say?
Yeah, it was a tough one for them to take, that one in particular, because everything was new at the time. COVID was new, symptoms were new. There was a lot we were trying to understand around that, and the difficulty being a screen, so an asymptomatic athlete being told, you can't play sport until we have these next steps, but the next steps are going to take X amount of time if we go down this route. So it's a difficult conversation to have as a kind of front-facing clinician. You just have to give people all the information and explain the reasons behind it and listen to people's concerns, I think. But we were lucky that we were able to find a way through that quicker, and hopefully having different centres, different areas where we can initiate the next steps quickly will benefit these decisions.
Yeah. And I get to visit loads of clinics around the country, and they're continually adding new services to what they're offering, VO2 max testing, strength testing. So, Aneil, do you envisage cardiac screening will become more prevalent and widely offered around the country and world?
I'd like to hope so. Cardiac assessments, ideally, the goal is to run a one-stop shop. They'll come for their ECG and their echo, and they can get their exercise test and a stress echo, and a cardiac MRI if needs be, as well as ambulatory monitoring, leadless monitoring devices so they can go back in their own environment and exercise and have their heart monitored. And that's what we're striving to achieve at the OrthTeam Centre as well. So I think that would be the goal to work towards. Obviously, that's going to vary from region to region, and infrastructure and expertise and funding and lots of other logistical challenges. But I think that's something that we can work towards to help mitigate some of the challenges that we've discussed today, especially wait times and unnecessary angst, or being able to reassure that individual and their family that there is a way that we can facilitate a return to exercise.
Brilliant. Guys, really appreciate your insight today. It's a really important topic. And thank you for sharing. So that brings the conclusion of this podcast, and we look forward to seeing you next time.